Good evening, everyone, and welcome to today's wonderful evening with Dr. Murali Bharadwaz. So, we had been traveling to finish the sleep promoting medicine. There are totally 3,500 points. Every day, around 2 hours, we shall finish around 200 points. And in the way, we will try to finish in a total span of around 35 hours the entire preventive medicine. 20 out of 20 you should score if you do the revision of these 3,500 points. So generally our class starts at 6 p.m. in the evening, 6 to 8 p.m. every day, Monday to Saturday. And on every Sunday, we have a grand test, full scale grand test, morning 9 to 12. If you are at Hyderabad, please come down to our Nampally center, take the question paper, solve the question paper. 12 o'clock, I will come to the center, and 12 to 3, we have a discussion. So totally 60,000 points in 19 subjects. We will sit together every day 2 hours, every week 2 hours into 6 days, 12 hours. So we'll finish it in about 45 weeks, the 60,000 points in entirety, along with every week full scale grand test. All these printed notes of the point wise notes is available to you as a printed notes, totally 2,500 pages. With that preamble, let's make the great beginning. Thanks to Dr. Teja for joining as usual. And it is the students in the live class and online. Good to see Dr. Ganesh Reddy, Sai Baba, and many more who are all online. And it is the students who are the inspiration that makes teacher to travel in the traffic jam and somehow reach the center and deliver the class. So, doctor, in preventive medicine, microbiology, you take any of these subjects, the most important topic is immunoglobulins. So, continuing our journey through point-wise revision of preventive medicine. What is the major immunoglobulin of all immunoglobulins? You know that GAMED, GAMED, 5 immunoglobulins. G is great, you can remember. So IgG comprises 85% of the total serum immunoglobulins. Highest amount of immunoglobulin is what you need to remember. IgG is predominantly extravascular. IgG is the only immunoglobulin to cross placenta. So you have the maternal blood, you have the fetus, and it cross placenta. You can remember G, Ganga. Ganga bahti hai. So IgG crosses, flows into the fetus is what you need to remember. IgM, it indicates recent infection, and it is 10% of the total serum immunoglobulin is what you need to remember. Now, what is the specialty of IgM? In IgM, you have disulfide bonds. There is a joining chain. There are light chains, heavy chains. Heavy has got a mu. Light chain has a kappa and lambda. This is the typical IgM structure. Once more, all these points are the high yield points even in microbiology. So IgM, because of its typical structure, has got a high agglutinating property. You know that antibodies are like idli. Complement is like chutney. You require a good chutney to eat good idli. So if antigen-antibody complex has to form, you require the mediation by the complement. So every time antigen-antibody complex is forming, complement levels keep decreasing because complement become used during the formation of antigen and antibody. So antigen is your mouth, antibody is the idli, and you require the chutney, which is the complement. So the very fact that complement levels decrease means immune complexes are forming and antigen and antibody are binding. So IgM is the one which has the ability to fix the complement. So complement binding is the property of IgM is what you need to remember. Then what is the specialty of IgA? Good to see Arun 35, Pavan Kumar Meena, Achan Khan, and many more who are all online. Very good. Yesterday, our class has, day before yesterday, class has 640 views with 0 advertisement and 8 likes. Actually, the more and more you hit the like button, the more and more will YouTube show to others who are preparing for the NEETPG. So IgA is 15% of the total serum immunoglobulins. It is predominantly found in secretions. That's what you need to remember. And whenever the mucous membrane is exposed, we eat something, organisms come. When the mucous membranes typically get exposed, IgA is the primary defense mechanism in the mucous membranes is what you have to basically remember. Then IgE, E is located in the submucous tissues. That's a point of interest. And Ig is very important for what? Immediate allergic anaphylactic reactions. Thank you. Immediate allergic anaphylactic reactions. IgE is responsible, is what you need to remember. Then you have normal immunoglobulins, specific immunoglobulins. Now you need to know what is the difference between normal immunoglobulin and specific immunoglobulin. You take 1,000 people, 1,000 donors. You take a pool of their plasma and you pick up the antibody rich fraction, and that collection is called normal IGs because these 1,000 donors are normal people. Whereas if you happen to collect the immunoglobulins, plasma, recently for COVID we are using plasma therapy, no? So if you collect immunoglobulins from the plasma of the recovered patients or the immunized patients, then that is called specific Ig is what you have to basically remember. So if you look at the normal Ig, that is from the normal 1,000 people, if you happen to take, 90% of that is IgG, because G is the greatest, right? Greatest amount of immunoglobulin. So where do we use the immunoglobulins which are collected from the normal people, human normal Ig? It is used in hepatitis, treatment of hepatitis, measles, mumps, rabies, and tetanus. So if you give a normal immunoglobulin, what is the type of immunity acquired called as? Passive immunity. Beautiful. Passive immunity. So for hepatitis A, measles, mumps, rabies, and tetanus, to provide passive immunity, we give human normal Ig is what you need to remember. Whereas human specific immunoglobulin, where do we use? Hepatitis B, varicella. What is varicella? Chickenpox. Diphtheria, we give specific immunoglobulin. That is either from the patients who are immunized or those who recovered from infection. Their immunoglobulin is being administered. You won't forget, no? Favorite MCQ. Non-human IG, which is the anti-sera, is used in diphtheria, tetanus, clostridium associated infections, that is gas gangrene, and also in botulism. And rabies also, non-human IG, that is the anti-serum, is being administered. Now, a word about disinfectants. We will read about it extensively in microbiology, but for now, oxidizing agents are the chemical disinfectants. Potassium permanganate is used in aquariums, and similarly to clean the feet before entering swimming pool. Similarly, for the fruit and vegetable storage, we use potassium permanganate, is what you need to remember. Hydrogen peroxide, what is its property? It is not only bactericidal, it is virucidal, fungicidal, sporicidal, is what you need to basically remember. And what do you use hydrogen peroxide for? To disinfect the surfaces in the hospital setting. As an antiseptic, to clean the wounds, discharging ulcers, we use the hydrogen peroxide, is what you need to remember. Silver is a very good chemical disinfectant. Especially, silver is used to prevent conjunctivitis. Topical therapy, we use silver nitrate and chlorhexidine gluconate cream to treat the burns. Topical therapy for burns. So that is what we need to remember. Then, what is pasteurization? 70 degrees, 30 minutes to kill the pathogenic microorganisms except spores. That's called pasteurization, is what you need to remember. Then where do we use microwave? To disinfect the contact lenses, dental instruments, dentures, milk, urinary catheter cultures, we use the microwaves. Then the thing is, if it is a micro oven, typically it is not reliable because the heat it produces is variable. That is the reason what do we use? Hot air oven. Hot air oven is 160 to 180 degrees Celsius for 1 hour. Is the temperature available. Please don't forget, this is a favorite MCQ. We use it for glassware, oily fluids, powder, etc., etc. Now, for the bedpans, urinals, surgical instruments, anesthesia tubes, we use the various disinfectors, flushing and water disinfectors. Ultraviolet radiation, we use for drinking water, titanium implants, contact lenses. To sterilize and disinfect the air, we use the ultraviolet radiation. That's a point of interest. So that is a bit story about the disinfectants. Each of this is an MCQ, doctor, and you need to be 100% sure. Father of evidence-based medicine, David Sackett, right? So today we are all our clinical recommendations. How to treat COVID? Should we give? Should we not give steroid? In the first wave, we gave lot of steroid, lot of pumps and pumps of steroid. Second, lot of alternative therapies like plasma therapy, this, that. Finally, we found nothing is useful. Only herd immunity vaccination can only solve the problem of COVID. That's what we finally concluded. So that is the beauty of the evidence-based medicine recommendations. Now, let us talk a bit about registration of the vital events. One of the favorite questions. Within how many days we should register birth? Less than 21 days. Within how many days we need to register the death? Less than 21 days. And the Hindu Marriage Act says, अगर शादी किया तो गवर्नमेंट को बोलना कितने दिनों में 30 days में within 30 days under Hindu Marriage Act you need to register the marriage. Pregnancy, there is no legislation yet in India to tell government that I am pregnant, right? You can be pregnant without telling government. Now, survival analysis. We calculate 5-year survival rate, 10-year survival rate, and all that. Similarly, insurance. Suppose you belong to a particular country. There is an average expected life. And suppose your age is 54, expected life is 72 in that country. All people die by 72. Suppose you say, give me 100 crore policy that before 100 years if I die, all my family will get that 100 crores, means they won't agree. Everybody in this country on average die by 72. Where is the question of giving you until 100 years? So we do what is called survival analysis. So we use Kaplan-Meier's estimator. It is also called product limit estimator for survival analysis. 3 to 4 points are asked in the entrance exam about Kaplan-Meier's estimator. So what is Kaplan-Meier estimator? It is a non-parametric estimation to estimate the survival function from the lifetime data of the population. Right? Now the question comes, what is meant by non-parametric estimation? I'll tell what is non-parametric. But before that, what is the advantage of Kaplan-Meier estimate to estimate expected survival of a person? It takes into account the censored data. What is censored data? A part of the sample is lost. The sample, for example, you have taken, how was that 10,000 people in Hyderabad survival in the past 5 decades? So during that process, some data is lost. Even the data, which is called censored data, is taken into account, which is the key advantage of Kaplan-Meier estimator to do the survival analysis compared to the other parameters available. Right? Now, life table approach means what? There is an actual observed survival over a period of time. There is a predicted score when you take a mock test. There is an actual score when you finish NEETPG. Maybe mock test scores may be showing negative scores because purposefully we make them very hard. Actual exam may be easy and you may be in a very high 3-digit positive score. So this is called actual observed. This is called expected. So life table approach is used for calculating the actual observed survival over a period of time. Now, what is the specialty of this approach, life table approach? Typically, there are patients at risk. For example, there is a factory, steel factory. People are getting mesothelioma in that. So there is a pattern of risk for these people working in steel factory. So last 50 years will give you certain analysis. What is the pattern? Based on that, you will predict today if somebody joins in this steel factory, what is the chance in future that he end up with mesothelioma? So to predict the onset of the events over a period of time based upon the previous pattern of the patients at risk is called life table approach, is what you need to basically remember. So in the life table approach, there are cohorts of patients, they are followed to determine the prognosis, and the probabilities are calculated about the survival for different lengths of time. How many people will survive for 10 years? How many people survive for 5 years? How many for 20 years based upon the previous people, how they survived. Understand? Huh. So, Kaplan-Meier method is basically an approach for life table analysis. So, Kaplan-Meier's method there are predetermined intervals generally which are used, 1 month, 1 year survival, etc. They are not used in Kaplan-Meier. That is the reason it is called non-parametric test. Non-parametric test. Right? So, Kaplan-Meier is very good if the study sample size is small, not big. This is another point. So, using Kaplan-Meier, everything, you don't do that in your lifetime. Because if you're a busy dermatologist, you are busy about the skin, how to learn a hair transplant and all. Who want Kaplan-Meier? But to get seat in entrance, you should know all this grass to be eaten and digested. Very good to see R. Kumar and many more who are all online. Right. Now, doctor, what is meant by median survival time? It is the length of the time that half the study population survives. That is called median survival time. There is another thing called mean survival time. Ramu lived how many years? Bhimu lived how many years? Somu lived how many years? 50, 60, 70, let us say. Then 50 plus 60 plus 70 divided by 3, that is called mean survival time. Whereas 60, which is the middle value, this is called median survival time. So median survival time is less affected by the extremes. For example, if somebody survived for 100, somebody survived for 10 years only. These are extreme values. While calculating the mean value, you are adding them all. Suddenly, if 100 or 1000 comes here, this whole value becomes altered. Whereas, to calculate the median, you are simply arranging it in the ascending order and taking the central value. So, it is not affected by extreme values. They are called outliers. So median is not affected by outliers. Mean is affected by outliers is what you need to remember. Then what is another advantage of median survival time? You are only checking for 50% of population deaths. How much time it took for 50% population to die. So you don't need to look and wait for all 100% to die. Only 50% need to die. You can calculate median. Whereas for mean, everybody's death you need to look for, and you should be alive to look for their death. And then you need to calculate. That is a problem of mean survival time. Then relative survival time, it is a ratio. So there is some expected survival and observed survival. Observed survival to expected survival, the ratio is called relative survival time is what you need to understand. Now, you all know odds ratio. In the case control trial, we use AD by BC. So that is what the probability of the association between risk and the effect is odds. So what is the relation between odds and probability? Odds is equal to probability divided by 1 minus probability. This is the favorite MCQ of examiner. So odds is equal to probability divided by 1 minus probability. Right? Whereas Probability is equal to odds divided by 1 plus odds will give you probability. A lot of times this comes as a question of examiner. So suppose 0.5 is the odds. So what is the probability? 0.5 divided by 1 plus 0.5 is equal to 0.5 by 1.5 is equal to 1 by 3 is equal to 33% is the probability. That's how you should do tomorrow's exam. You need to calculate. All right, doctor. Now comes the dirtiest question on the planet Earth. Rickettsial diseases, rickettsial etiological factors and reservoirs and vectors. I used to hate this. Every time I read, I used to forget. In MD entrance exam days, we can't help it. Epidemic typhus, Rickettsial, Provozakiae. I have never seen the epidemic typhus. I have never seen Rickettsial, Provozakiae till now. One single case also sitting in India, but for entrance exam. But tomorrow. Endemic typhus, Rickettsial typhi. Reservoir rats. Scrub typhus, Rickettsial susugumushi. Reservoir trombiculoid mite. So one of my friends, Srinivasa Murthy, he used to do it like a puja, get some flowers. Indian tick typhusai namaha, Rickettsial canoriae namaha, like that. So playfully, we all overcome the drudgery of preparation and ultimately become consultants. So that should be, there's no other way. You have to, if you say, oh no, I can't read, I forget, my neck will pain, my tongue will pain. Oh, no. Anything pains, you still need to. Indian tick typhus, Rickettsial canoriae. Reservoir is rodent. Rocky Mountain spotted fever, Rickettsial. Reservoir is rodent. Rickettsial pox, Rickettsial acari. Reservoir mice. Trench fever, Bartonella quintana. Reservoir humans. Q fever, Coxiella burnicii. And it is transmitted. There is no vector for it. It is through the droplets. Reservoir is cattle, sheep, goat actually. Then draconculasis, only goat. Cattle, sheep, goat. Draconculasis, Draconculus medinicis, reservoir humans. Ascariasis, Ascaris lumbricoids, reservoir humans. Ankylostomiasis, Ankylostomadiodinale, reservoir humans. इसको दिमाग में डाल दो. Don't tell entrance exam preparation is intelligence. Nothing. God is a good do. Entrance exam preparation is 60,000 points you should know. And I am sitting here for 600 hours to do the revision of 60,000 points with you. Automatically you'll get C. But 600 hours you should be ready to slog with me. And you need to bookmark what points you want to revise in the 2,500 pages notes. If you don't get seat, मेरा नाम मुरली भरद्वाज नहीं होगा. ठीक है? Now, generally diseases, doctor, they're all communicable. They are not communicable during incubation period, but only, actually this is not communicable. They are communicable. Only 4 communicable diseases are communicable. It's not communicable. Communicable. 1 minute. Now only will change. Diseases are not नहीं है, एक communicable है. So only 4 communicable diseases which are communicable even during the incubation period. You have to be very sure. Measles, that is even before clinical symptoms come, they are communicable. So what are the 4 conditions you should never, ever forget? So measles, chicken pox, whooping cough, hepatitis A, they are communicable even during incubation period. Only 4 communicable diseases. Now let us talk about screening tests. Pepinicolau smear for cervical cancer, for breast cancer, screening test. Breast self-examination and mammography. Then for oral cancer, bimanual oral examination. Then ELISA, rapid test. ELISA is very rapid and simple for HIV under National AIDS Control Program. Western blot is confirmatory, but for screening only ELISA. Urine for sugar, random blood sugar for diabetes. Alpha-fetoprotein for developmental anomalies. Distal rectal examination, prostate-specific antigen for prostate cancer. Fecal occult blood for colorectal cancer. These are all the classical screening tests is what you need to remember. What kind of diseases do you do screening is a very, very important question. First of all, the disease should be an important health problem. And right then, because Creutzfeldt-Jakob disease, you don't do screening because it is not very important health problem. There should be an effective treatment. Suppose you conduct mock test and tell a student that you know nothing. What is the use? You have to do the mock test, which is like a screening test, and tell the student, देखो ये चीजों में आप बहुत weak चल रहे हो, you have to improve. So effective treatment should be available. Facilities for diagnosis and treatment should be available. Suppose you do some test and say, maybe because of this test, it looks like you have a disseminated cancer. Disseminated brain cancer. You don't have MRI, you don't have treatment for it. What is the use of doing screening test? Then there should be latent or early asymptomatic stage. Because ideally a screening test is supposed to make a diagnosis very early. Suppose if the symptoms appear so clearly, all rash is there, what is the need of screening test? Right? Even before the rash came or the symptoms came, if there is a way you detect it, then that kind of diseases are worth to be screened. So there should be latent or early asymptomatic stage before such kind of diseases are good for screening. There should be a test to confirm the diagnosis, and the test should be acceptable to the population. Suppose if you say, to make a diagnosis of depression, I will do per-rectal examination of entire population. People should be ready to accept the PR, no? Right? So the test should be acceptable to the population. And the natural history of the disease should be adequately understood. Suppose you do screening test and say, like an astrologer, it looks like, I don't know how to say, it looks like this condition whose natural history I don't know, but you have that. Suppose if you say that, that fellow will beat you and go. So the natural history should be adequately understood. There should be an agreed policy on who to treat. A pulmonologist, cardiologist, nephrologist, or who? And the total cost of finding a case should be economically balanced to the medical expenditure. A lot of times we do this mistake. You will write CACT, you will write MRI, you will write everything. By the time you diagnose that it is pulmonary TB, patient spent all the money and he has no money to buy medicines for TB. That is bad. So the total cost of case finding should be economically balanced in relation to the medical expenditure. And case finding should be continuous process, just not once and for all project. So that sometimes what happens, no? Case finding, you tried a screening test. But unless the disease is to certain level, then only it will detect. Maybe the disease did not reach that level. Then what is the use? Suppose today you did a test. You found 118 is the fasting blood sugar. Only one time you did and declared that you don't have diabetes, get out. But next day he has got 140. Right? So screening should be, the case finding in screening should be a continuous process, not just once for an all is what you need to remember. Now there are two types of screening: prescriptive screening and prospective screening. What is meant by prescriptive screening? People are screened for their own benefit. The whole idea of prescriptive screening is to detect a case. And in this, you are going into the community and trying to detect the cases. There is no request made by them, please do screening. That is called prescriptive screening. Understand? Example, neonatal screening. Neonate won't request you, please, sir, do my thyroid profile so that you may detect hypothyroidism, so that if in future I become better and I can take NEETPG entrance student. The infant doesn't say. So neonatal screening is a prescriptive screening, no specific request done. Purpose is to detect the hypothyroid cases, right? And pap smear. You will go into community and a particular age group, all mothers you will look for. Urine for sugar. They're all examples of what? Prescriptive. Prospective. People are screened for others' benefit. Like people coming from America are screened for COVID. That is what? Prospective screening. And the whole idea of prospective screening is simple. Remember, COVID screening is prospective. Disease control. So this is a very potential MCQ. What type of screening is COVID screening? Prescriptive or prospective? Your answer is prospective. Prospective happens by a specific request from authority. So screening of immigrants, HIV screening among sex workers, that is all what prospective screening is what you need to remember. So what are the most common neonatal disorder screen? Neonatal hypothyroidism. And from where do you collect? Umbilical cord blood. From there you take the sample for detecting neonatal hypothyroidism. And which test? What are the two tests that you do? It is not T3, reverse T3 or anything. You do TSH and T4 for screening neonatal hypothyroidism under National Hypothyroidism Program. Guthrie's test. It is for the mass screening of phenylketonuria. And you pick up the blood sample from the heel of the baby, newborn baby, heel prick. What time? Between 7 to 10 days. This is an MCQ. You need to remember. And why 7 to 10 days? Because 0 to 3 days of life, even he has got phenylketonuria, you cannot be able to use Guthrie. Guthrie can detect PKU and even galactosemia and maple syrup. So for phenylketonuria, what are the substances in the plasma that are detected by the Guthrie? Phenylalanine, phenylpyruvate, phenyl acetate, they are the ones which are detected. Guthrie is called semi-quantitative test. So there are two types of screening tests, qualitative, quantitative. It is a quantitative test, semi-quantitative test. And today are we using Guthrie? No, sir. Because today we are all using tandem mass spectrometry, which has replaced Guthrie's test is what you need to remember. Now, whenever you do screening tests, you have A, B, C, D chart. Right? So A, B, C, D. So who is A? A is true positive. That means disease is positive. Test is also positive. Then what is D? False positive or B. That is disease is not there. Still test is positive, false positive or B. Then, I'm sorry. Yeah, B is false positive. D is true negative. D. Disease is not there and test also turned negative. That means it is a true negative. Then what is C? C is false positive. False positive means disease is positive, but the test is negative, is what you need to remember. So, where are the total population who have the disease? All these people have the disease. A are true positive, B, C are false positive. Right? Sorry, C are false negative. False negative. Right? So, that is the reason we need to remember. All the diseased patients are A plus C. That means true positives and false negatives are what? All diseased. Then total population not having the disease, who are healthy are who? The B plus D. So who are B, who are D? D are true negatives. B are false positives. So please remember, those who don't have disease are false positives plus true negatives. Those who have the disease are true positives plus false negatives. You'll remember for me? Good. Now comes formulas. Before we conclude with today's wonderful evening, doctor. Good. Sensitivity. What is the meaning of it? It is the ability to identify correctly all the people who have the disease. Sensitivity is, the whole purpose is detecting true positives. Remember, sensitivity. This is N, but you detect T. Right? Then specificity is the ability of the test to detect true negatives. Specificity P is very big, and it is detecting N, who are the true negatives. Sensitivity is N, which is very prominent, and it is detecting true P, that is positives. That's what you should remember. So, what is the formula for sensitivity? A by A plus C. What is A? A is all true positives. So, C are false negatives. So, true positives plus false negatives into 100. So what is true positives plus false negatives is called? If you look back, true positive and false negative are the people who have disease. So who are truly having disease divided by all the people who have the disease. A plus C is all the people who have disease. That is true positives and false negatives. All of them have disease. True positives are detected. False negative is, though they have the disease, they are not detected. So these have disease, these also have disease. So all diseased in the denominator truly found positive for the screening test is true positives. That is the sensitivity. You'll remember this formula, right? Specificity, ability to detect who do not have disease. Those who are do not have disease, that is those who are healthy, don't have disease is specificity. That's the reason true negatives, they don't have disease and test also turn negative, true negatives. By all the people who do not have disease, true negatives plus false positives. Who are false positives? They do not have disease. True negatives, they too do not have disease. Do not have. These also do not have. But these people are found to have test negative. Hence, they are called true negatives. These people do not have disease, but tested positive. Test is positive. That's the reason they're called false positive. So true negatives plus false positives totally are the people who do not have disease comes into denominator. True negatives are in the numerator. That is specificity is what you need to remember. Then positive predictive value. It is the ability of the screening test to identify correctly all those who have the disease out of all those who tested positive, right? So those who tested positive include, who are the people who are included in the test positive? Those who have disease and turned positive, and those who don't have disease and turned positive, that is false positives. True positives plus false positives are what? All positives. Out of that, whom do you want to detect? True positive people among all positives will give you positive predictive value. Whereas true positive by all diseased is called who are diseased. True positives plus false negatives. This is sensitivity, right? So true positive by all diseased is sensitivity. True positive by all positive is positive predictive value. You'll remember this? Then what is negative predictive value? Ability of the screening test to identify who do not have the disease out of all the people who turn negative for a screening test. So those who truly do not have disease are true negatives. True negatives out of all the people who turn negative. So who turn negative? True negatives are negative and false negatives are negative. So of all the negative people, finding true negatives is called negative predictive value. And finding true negatives of all the people who do not have disease, who do not have disease is called as specificity. एक दो मर्तबा आप रिविजन करो भैया, గుర్తుంటారా? ఫట్ చెప్పాలి డాక్టర్ సాబ్. ఎంట్రన్స్ లో సీట్ అంటే అదే సెన్సిటివిటీ. కమాన్. True positive by true positive plus false negative, otherwise true positive by all the people who have the disease. Specificity, true negative by true negative plus false positive. That is true negatives out of all the people who do not have the disease. Sense specificity. Positive predictive value. True positive by all positives. True positive plus false positive. Negative predictive value. True negatives by all negatives, it is true negative plus false negative. 1 mark will be there in your pocket. Okay? So what is percentage of false positives? False positives divided by false positive plus true negatives is called percentage of false positive. Denominator में क्या होता है? Percentage of false positives में false positives plus true negatives will be there in the denominator. Percentage of false negatives means false negatives divided by true positive plus false negatives will give you percentage of false negatives. Now, what determines the positive predictive value of a test? So what is positive predictive value? True positive by all positives. True positives plus false positives. It depends on the positive predictive depends on the sensitivity, specificity, and even prevalence. All the three will decide the positive predictive value. Positive predictive value is directly proportional to the prevalence. Positive predictive value. For example, prevalence of diabetes is very high in the community. If you use the glucometer, the chance of the true positives of all positives is higher. Right? Whereas the prevalence of COVID-19 currently is low. So the test positive predictive value is low. That is, if somebody turned out to be positive, then he is a true positive. The chances are lesser if the prevalence is low. When the prevalence is high, the chance of somebody who is positive turning out to be truly positive is higher. That's the point you need to remember. So as the prevalence increases, positive predictive value increases for the screening test. So what is meant by likelihood ratio? In likelihood ratio, we are looking for if at all test result turns positive, the odds of having the disease. Suppose if आपने एक टेस्ट दिया, if the test result is positive, what are the chance of odds, probability of my truly having the disease? That is called likelihood ratio. In likelihood ratio, to calculate that, you will use both sensitivity and the specificity. So the likelihood ratio of a positive result tells you how much the odds of the disease will increase whenever the test is positive. And how do you calculate? Sensitivity divided by 1 minus specificity. Sensitivity divided by 1 minus specificity gives you likelihood ratio of positivity. So what is my likelihood ratio of positivity? If a test result is positive, what is the chance of me having, odds of me having that particular disease? That's called likelihood ratio for positivity. And it depends on sensitivity, specificity. So sensitivity divided by 1 minus specificity will give you likelihood ratio of positivity. Likelihood ratio for negative test. So what are the odds of me not having the disease whenever the test is negative? That's called negative likelihood ratio. Negative likelihood ratio is 1 minus sensitivity by specificity. Whereas earlier, sensitivity by 1 minus specificity will give you positive likelihood ratio, whereas 1 minus sensitivity by specificity will give you negative likelihood ratio. Just remember the formulas, doctor, don't worry. Did we understand, not understand? छोड़ दो एंट्रेंस के लिए Then what is meant by post-test odds? Once you have specified the pre-test odds, that is prior to testing, you have created a likelihood probability of having a disease. That's called pre-test odds. For example, elderly man, ECG test is like this, echo test is like this. Based on that, you thought, right? Before I do coronary angiogram, this is the probability of he having coronary artery disease. Then coronary artery disease has certain likelihood ratio. So if you multiply that likelihood ratio with the pre-test odds, then that will give you posted test odds, is what you need to remember. So post-test odds is equal to pre-test odds multiplied by likelihood ratio is the formula that you need to remember. For any screening test, there is certain things called reliability, precision, repeatability, and consistency, and reproducibility. Reliable, precise, repeatable, consistent, and reproducible. Yesterday, after the wedding is over, I slept at morning 4 o'clock. I'm sorry, I'm very sleepy. This is not what I am generally. But today I just came for you, Dr. Teja. I thought if Teja comes for me, I should go for Teja. So, generally my son who married yesterday, he drives me from home to the class. So today, the poor guy's nuptial night is there. So I said, okay, spend with the newlywed bride. I will go drive myself and come to class. I teach very fast, but I drive very slow. So that's the reason I came a little late. So Pearson product correlation coefficient, Cronbach's alpha, these are the ones which are used to test for the reliability. So the test giving consistent result when it is being repeated more than once on the same individual or the material under the same conditions is the definition of reliability. Whether your girlfriend is angry or happy, whether she is in the premenstrual phase or postmenstrual phase or puerperal stage, if she constantly says, you are the hero of my life, then that is called reliability, precision, repeatability, consistency, and reproducibility, right? So what is reliability dependent upon? It is dependent upon observer variation, biological variation. That's also very important. If she is having premenstrual depression, psychosis, right? Then at that point of time, if you go and propose how beautiful you are and you start poetry, she may end up in punching you. So biological variation, errors relating to technical methods. So technical method to check how much your girlfriend likes you. On WhatsApp, she liked you. On Facebook, she liked you. On Instagram, she liked you. But when you actually went for dating, she found that you are a psychotic and depressive, maniac depressive. So the technical method of checking how good you are didn't work out. It worked out well in WhatsApp and the phone call, not in the coffee day when you are sitting together. So reliability depends on observer, biological variation, and errors relating to technical method. So what is intra-observer variation? Same observer taking 2 or more readings get varied results. For her birthday, she is happy and you enjoyed that moonlight. But her sister's birthday, you went and she is where she made you feel panicky. That is called intra observer. You are the same observer who is watching your girlfriend. Then what is meant by inter observer variation? Variation between different observers on the same subject is called inter observer. She is very sweet to you, but she is too unbearable for your roommate. When he started speaking, he said, "Hold, she is not my Bhabhi, please don't marry her." So, inter-observer variation is what you need to remember. Then, reliability of a screening test depends on biological variation. So, the changes in the parameters used. Suppose you did an experiment in centimeters when you calculated, it is coming precisely. But in meters, you are calculating if it did not come out that precisely. That is called biological variation. Variation, perception, and answers of the patient. Regression to the mean, they all lead to biological variation of the test results of a screening test. Errors related to technical methods. You may be using defective instrument, a BP apparatus which is not working well, whose mercury is all different. Erroneous calibration, faulty reagents, inappropriate, unreliable tests, anything can cause change in the reliability and variation. So what is meant by validity? Validity and reliability are different. Precision, see, remember what are the synonyms here? Reliability, precision, repeatability, consistency, reproducibility, they're all same. Whereas validity and accuracy, they are different. It refers to what extent the test measures what it is supposed to measure. Suppose your test is supposed to measure a moderately severe diabetic patient, right? And also mildly diabetic patient. Suppose if your test is measuring only the people who are moderately diabetic but not mildly diabetic, then it is not accurate. So accuracy and validity means the extent the test can measure compared to what it is expected to measure. That is called validity or accuracy. So validity depends on what? Once more, it depends on sensitivity, specificity are the two parameters on which the validity is dependent upon, is what you need to remember. So doctor, that brings us to the end of today's wonderful evening. Every day, we will make it a point that we meet at 6 o'clock to 8 o'clock. And thank you so much for coming to the session, both the online students and also the offline. And we make it sure that 600 hours we will study like this together. I will give you 2,500 pages of printed material of the notes. And invariably, the 200 questions come from this 60,000 points. Out of this, 40,000 points don't need second revision. Hardly 10,000 points to 15,000 require second revision. 5,000 points last 30 days. That is a simple strategy. Got it? Sure. Thank you so much for coming.